Application of Cohen's Callipers for cervical dislocations. Cervical dislocations represent a spectrum of osteoligamentous pathology that includes unifacet and bifacet dislocations. 75% of all facet dislocations occur within the subaxial spine. The mechanism of injury involves flexion and distraction forces with or without an element of rotation. These injuries include motor vehicle incidents, sporting accidents, and falls. The Ferguson and Allen classification of subaxial cervical spine injuries is typically used for research and not commonly applied in clinical settings. Fracture or dislocation of the cervical spine should be suspected in any patient involved in a high-velocity injury. These include neck pain, paresthesia, and pathological reflexes. Particular emphasis should be placed on the neurological examination. The principles of management include imaging of the cervical spine, reduction, and stabilization. Although CT scans may identify cervical spine injuries, sometimes missed by plain radiographs, it has not yet replaced the 3 standard plane views listed on the screen. Ideally, all acute cervical facet dislocation should be managed with emergent MRI. However, this is not practical and is therefore often not used in emergency situations. Flexion distraction injuries are classified as unstable injuries, and therefore a patient that arrives with a complete, severe neurological deficit and deteriorating neurology needs urgent closed reduction. The benefits of reduction are listed on the screen. There are 2 types of reduction, open and closed. For one to perform a closed reduction, the patient needs to be awake and cooperative, as a neurological evaluation must be done throughout the procedure. A closed traction reduction cannot be performed in a patient with any of the following: a skull fracture, severe soft tissue degloving, or a patient who is unconscious or unable to cooperate. The following video demonstrates practical steps in the application of the Cohen's caliper. The patient must be awake and cooperative. The patient is placed in a reverse Trendelenburg position with shoulder straps. Analgesia, such as morphine, is to be administered prior to commencing the procedure. Monitoring of the cardiopulmonary function during the process to avoid hypoperfusion. Traction tongs applied 1 centimeter superior to the pinna of the ears after administration of local anesthetic. Before proceeding, palpate locally to prevent perforation of local vascular structures. Start with 5 kilograms in slight flexion, checking the alignment and over-distraction on lateral X-ray. Add 2 kilograms for every cervical level every 15 to 20 minutes. For example, a C4 injury will require a maximum of 8 kilograms in 1 hour. Repeat radiograph checks until the cervical spine has been distracted to the point where the facets can be unlocked and reduced by extension. Serial neurological examinations must be done each time weights are added. Once reduction is achieved, extend the spine and reduce the weight to about 5 kilograms. It must be noted, however, that surgical reduction is the definitive management and ultimate standard of care for distraction flexion injuries, without which patients continue to complain of pain and instability.